I am so honored to be part of this six-part web series. And I feel like I've grown up with Heartland because I've been going to San Antonio and learned a lot from the people at Heartland and have enjoyed working with them over 30 years. I'm going to be talking today about TB disease in children and pregnant women. So our objectives today are, I'm going to highlight some of the unique aspects of TB disease in children, including the clinical presentation, laboratory findings, and also review the diagnosis and treatment of disease in children and pregnant women. In the end, I'm going to talk a little bit about some of the new shorter course therapies, which we're excited about. Here, this is a graphic display of the risk of disease progression in patients infected with TB at different ages and with different medical conditions if they haven't received any treatment. And this is from a number of different studies over the years, mostly in the children. It's from before we really routinely treated latent TB infection, so back in the 50s and 60s. And looking at the age here, you can see that young children in the first year of life have a very high risk of around 50% that they will progress to disease if they're not treated for latent infection. The risk is also high in children under 4, around 24%. We know that healthy adults' risk is around 5 to 10% over a lifetime. And in the last few decades, we've learned that people with diabetes also have an increased risk. And of course, patients with immunosuppressive disorders as well. In the early 2000s, a study out of Africa confirmed these data in the modern day, finding the same information that children in the first year of life have about a 50% risk of progressing to disease. And mostly, while it's about half pulmonary, we also see a high rate of miliary or TB meningitis. This is an older slide looking at the timetable of tuberculosis. And I really like this graphic because it shows over time from day one being when you first become infected over a 3-year period. And we know that it takes about 8 to 10 weeks for the skin test or the blood test to turn positive after infection. What a lot of people aren't aware of is how quickly patients can progress to miliary or TB meningitis within a month of infection, with a peak really in the first few months, going out to about 9 months. So a patient could actually become sick with disseminated disease before their skin test or blood test have converted. And in young infants, this is especially important to remember. I also want to look at just sort of the distribution of what types of TB we see in children compared to adults. This is some older data from the CDC showing how adults and children both have mostly pulmonary disease, whereas children have about 25% of extrapulmonary disease, and this includes lymph node disease, and in adults, it's about 15%. Now I'm going to break this down into the different forms of extrapulmonary disease that we see. And on pediatric patients, overwhelmingly around 65% is lymphatic, and this includes the interthoracic lymph nodes. And then look at meningitis at 14%. And compared to adults, pediatric patients have a higher risk of meningitis, a higher risk of extrapulmonary disease, and a higher risk of progression to disease if they're infected. So reactivation TB is the type of tuberculosis that I learned about when I was in medical school, and this is mostly what we see in adults and teenagers. Most of these patients have the classic symptoms of tuberculosis. And this usually occurs years after a primary infection that may have been undetected or untreated. And they usually see cavitary disease. It likes to recur, of course, in the apical parts of the lungs, where you can see cavities here on this patient. This is a patient I took care of, a teenager. These patients have usually a sputum production. They have a lot of AFBs on their sputums, and they're considered contagious. What we see in children is more a different picture. It's what we call primary disease. So it can also be seen in adults if they're being infected for the very first time, where usually not cavitary. The classic X-ray with primary disease includes hilar lymphadenopathy, infiltrates really in any lobe. It doesn't tend to be in the apices, and a miliary pattern if they progress to disseminated disease. Patients with primary disease have low numbers of bacteria, sometimes called paucibacillary disease, and the AFB smears are negative in most of the patients. And cultures are also negative in over half of the patients with primary tuberculosis. And because of this, the low numbers of organisms, the fact that children can't really forcefully cough up much sputum, most children under 10 are not considered contagious unless you have that rare child that has a cavitary disease or smear positive disease. So what kind of symptoms do kids come in with TB disease? It's extremely variable. They may have cough or other respiratory symptoms. You might hear wheezing, crackles, or decreased breath sounds on your lung exams. Lymphadenopathy and lymphadenitis is fairly common in children with TB. Sometimes they'll present with just a persistent fever, weight loss, failure to thrive, or if the child has meningitis, they may have headache, vomiting, irritability, or focal neurologic findings. But unlike adults, over half the children with TB have no symptoms at all and may even have a normal physical exam. So this is important to remember. They have a milder form of the disease with lower number of bacteria, and so they're less symptomatic. So how do we make the diagnosis of tuberculosis in children? Of course, if we have a positive culture, we've hit gold. This is the gold standard. But what we're usually left with is a clinical diagnosis. And the clinical diagnosis includes an abnormal X-ray, laboratory, or physical findings consistent with tuberculosis, and at least one or more of the following: either a tuberculin skin test, an IGRA being positive, or we've identified a contagious adult source case. The course may be consistent with tuberculosis, or the patient improves on TB therapy. This is a study that was published in 2015, where an international panel came up with a case definition. It's a busy slide. We're not going to go through the algorithm completely, but I just wanted to point out, here's the patients with a positive skin test. I'm sorry, with a positive TB culture. So this is your gold standard. And then these two groups over here are your groups with a clinical diagnosis. The middle group being patients that have either a positive IGRA or skin test and at least one clinical criteria. And then if their IGRA or their skin test are negative, they have to have at least two clinical criteria. And this was produced to help have a standard for the clinical definition of tuberculosis in children. The classic triad that we see in most cases, we're going to have either a positive IGRA, skin test, an abnormal X-ray that looks like TB, and infectious contact. This will be our most likely and most helpful clinical diagnosis, especially in those patients with negative cultures. So what about the source of infection? The contact investigation can be so important in helping us in supporting the diagnosis in the child, especially if the child has negative cultures. The source is usually an adult or a teenager with contagious TB and often has a cough and has symptoms. Sometimes we find this person after we've identified the child and we start asking about family members, babysitters, or neighbors that may be around the child. Sometimes the the adult contact is found first, and then we are seeing the child because they've been exposed to this person. The AFB smears are usually positive. Most of these patients are going to have positive expert or cultures, and the susceptibilities can help us in deciding which are the best treatment for the child. Now, Dr. Megan Devine and Dr. Susan John did a beautiful job last month talking about the X-ray findings in pediatric patients and pregnant women, but I need to touch on this since it's an important part of our diagnostic criteria. So hilar and intrathoracic lymphadenopathy are classic for tuberculosis, and in children, it's usually TB until proven otherwise. If you have a miliary pattern on the chest X-ray, this is also highly suggestive of tuberculosis. And of course, apical cavitary lesions, not so common in children, but if you see this kind of an X-ray, it's TB should be high on your list. If a patient has meningitis from tuberculosis, there are typical findings that are well described in the literature, including a basilar inflammation, and I'll show a few examples of this in some cases we're going to go through. Now, other findings you might have, but are not really specific to TB, are going to be a lobar pneumonia, which could be in any lobe of the lung, and especially in kids. And then we sometimes will see pleural effusions. And of course, there's many other types of infections in the chest that could cause these kind of findings, but it could be consistent with TB if your evaluation turns up other criteria. So here's a few examples of these findings. Here's a child that had a family member with tuberculosis and has this large opacity here in the left hilar area. And you can see it on the lateral as well. So this is hilar lymphadenopathy. And when we were evaluating this child, when we saw this chest X-ray, we made the diagnosis of TB disease and started this child on RIPE therapy. This is a 6-week-old that I took care of that came in with respiratory failure and has a terrible X-ray. This child has pleural effusions on both sides, has diffuse infiltrates throughout the chest, consistent with miliary TB, and then has also this same area, this large left hilar lymph node. The lymph node is what had our radiologist put TB high on the differential. And in fact, the child was intubated and we were able to get tracheal aspirates, and the patient had AFB smear positive disease. It turns out this was a case of congenital tuberculosis. The mother was worked up and evaluated and found to have endometrial disease. Both baby and mom were treated and did well. And after this baby had a very long course in the hospital. Now, a miliary pattern classically has micronodular infiltrates through all lobes of the lung, and in fact, usually is all over the body. And in children, here's another example with the miliary pattern here seen on the left and on the bottom right, and then has just this really dense infiltrate. This child had been referred to us for TB exposure, but had missed a couple of appointments and showed up in the emergency room with this chest X-ray and also had meningitis as well. She was successfully treated and did fine. And then adenopathy being very important. We do see it in the hilar area and in the other parts of the chest, but we also see it in peripheral lymph nodes, most commonly in the cervical lymph nodes, as you can see here. And this same patient had abdominal pain, so a CT imaging showed these lymph nodes in the abdomen as well. TB classically has this ring enhancement with a hypodense center, which you can see on both of these images if you get a contrast imaging. And then, of course, cavitary disease. And here we have a teenager with right upper lobe cavities, also has a left lower lobe infiltrate or consolidation. Mostly we'll see this in adults and teenagers. Occasionally, I've only seen a few infants with cavitary disease. This is an infant that had a big infiltrate here and then went on to develop cavities with their TB disease. So peripheral lymphadenopathy is another thing we must check for carefully on the physical exam. You want to carefully examine the cervical lymph nodes being the most common after the interthoracic lymph nodes. Supraclavicular, axillary, and inguinal nodes all need to be examined. Now, kids have a lot of upper respiratory infections, maybe strep throat, or scratches or bug bites on their skin, and they may have small reactive lymph nodes in these areas that measure a centimeter or less. This is usually not TB. If it's TB disease, usually the lymph nodes are going to be larger than a centimeter. The diagnostic recommendation would be fine needle aspirate or an excisional biopsy sent for pathology to rule out other causes, and also make sure they ask for TB culture and other cultures. These lymph nodes may be kind of quiet and not very inflamed, or they may progress with this kind of friable, violaceous, or red colored skin and have drainage, chronic drainage coming from the lymph node. These can be real hard to treat. Sometimes they become more inflamed with treatment and may continue to drain. And then here's a baby with a lymph node in the axilla. So I wanted to present just a few of my cases to make some of the points we want to talk about today. So this young man was a teenager who had a 15-year-old teenager who had a 5-week history of a mass in his neck. He also had fever and a 20-pound unintentional weight loss. He had no history of foreign travel, and he had no known exposure to tuberculosis. He was a big kid. He was a 100-kilogram football player, and he had 5-centimeter cervical lymphadenopathy on physical examination. His lungs were clear. His skin test was 0 millimeters, and his chest X-ray was normal. So we got some imaging of his neck, and you can see he's got quite a mass here in his cervical area, and with a number of lymph nodes that were easily palpable. So because of his skin test being negative, really tuberculosis was still on our list, but other things came up too. We thought about lymphoma, we thought about leukemia, other types of possible infections, including HIV and non-tuberculous mycobacterium. We see a fair amount of Mycobacterium avium responsible for positive lymphadenopathy. So on laboratory, we got a CBC with a peripheral smear. We got infectious workup was also negative for HIV, Epstein-Barr, and Bartonella. We did get a biopsy of the lymph node, which was negative for cancer. The AFB smear was negative, but they did see granulomas on pathology. We sent a quantiferon, which unfortunately took 5 days to come back, but once it came back positive and these other tests came back negative, I felt like we had enough clinical suspicion to go ahead and start him on TB treatment for his lymph node disease, fever, and weight loss. And in fact, 5 weeks later, he did grow tuberculosis from his lymph node, and it was susceptible to all drugs. And he also improved on therapy and gained back weight, and the lymph nodes went away. So what about collecting specimens from children? Children are not usually, young children are not great about coughing up sputum, so sometimes we have to use other methods. On the Curry International TB Center, there is a protocol for getting nasogastric aspirates from children. The theory is in kids with pulmonary disease, overnight, the respiratory cilia will bring up the bacteria from the lungs, which will be swallowed into the stomach. Usually we do this as an inpatient procedure, but it can be done as an outpatient. It requires overnight fasting, and we lavage with normal saline. If you collect 3 early morning gastric aspirates, almost always our AFB smears are negative just because of the children having the paucibacillary disease, but we do get a positive culture in around 40% of patients. The literature shows a range of around 20 to 50%. Another way to collect specimens is through induced sputums. This is recommended for children around 3 or over. This is an outpatient procedure. Also, fasting is recommended for a few hours before the procedure. And you want to give the child nebulized hypertonic saline and then suction the nasopharyngeal area. One specimen in this study was sufficient with a yield of around 40% on culture, although I've seen other studies with a lower yield. And this can be done in kids 3 and over. Another method, if the child is having sedation or anesthesia for some reason, is a bronchoalveolar lavage. This is just as good as 3 early morning gastric aspirates and is helpful in children that require sedation. From lymph nodes, you can either do an excision or an FNA, fine needle aspirate, and you want to send for path and culture. The literature says between 30 to 70% yield. My personal experience has been more like 20 to 30%. And I think it's because we mostly get fine needle aspirates from these patients, so it's a relatively small sample. For TB meningitis, most experts do recommend for children a year or less with TB disease that you rule out meningitis because the incidence is high in this age group. So an LP would be important. The sensitivity for culture from the CSF is really pretty low, around 20% on average. You will improve your sensitivity if you send extra spinal fluid. So once the studies come back, the routine studies, and you're thinking about TB, what I do is call the lab and say, any spinal fluid you have left over, please add that to the TB culture. Or if the child's having a repeat lumbar puncture for some reason or has an extraventricular drain, we can collect additional CSF or sampling. This will improve your sensitivity. But basically, the bottom line is that a negative smear, NAT, or culture does not rule out disease. And this is true in both children and adults, but especially true in children. And the cultures and sensitivities in children that have negative, if the child has negative cultures, the sensitivity and culture from the adult source case can be helpful in guiding the treatment for the child. Now I want to go on to the nucleic amplification test and other molecular testing. This has been a huge advance in the diagnosis for TB. These tests are highly specific with rapid results, and the expert has the advantage of telling us if the organism is rifampin resistant. Unfortunately, in the United States, the FDA has not approved these tests in smear negative samples, so it doesn't help us a lot in children. I do sometimes twist the arm of my microbiologist and they will run the test for me, but it's not FDA approved. This was a study in 2017 looking at adults with culture positive but smear negative pulmonary disease, and they found the expert to have a sensitivity of between 65 to 80% with an almost perfect specificity at 99. A Cochrane review of expert versus expert ultra in children that were culture positive for TB showed almost exactly the same results, with 65 to 73% sensitivity and specificity near 99. Interesting in those with pulmonary disease, that gastric aspirates were the best sampling, better than sputum, better than stool, and the nasopharyngeal aspirate was the lowest for the sensitivity. Lymph nodes, now these are in lymph nodes that grew TB on the culture, had a sensitivity in the expert at 90%, Spinal fluid had a lower sensitivity, around 54. But I feel like these tests are really helpful, especially when you're having a hard time making a diagnosis. And if you can get these tests, if they're available to you, you may have increased sensitivity, even in smear negative patients. So another case that I took care of was this little 6-month-old baby whose mother was diagnosed with tuberculosis disease. So how do we determine the risk to the child? Important to note, how's the mother's x-ray? What are her AFB smears? How long has she been on treatment? This is the mother's chest x-ray, which is horrible. She has bilateral cavitary disease. She has AFB smear positive, and she's just starting her treatment. So she's at very high risk of transmitting tuberculosis to her family and other contacts. So how do we evaluate the baby? So when we saw the baby had had a cough and fever for a couple of weeks. They'd been seen at their primary care provider and also had been twice to urgent care and sent away with no treatment with the diagnosis of a viral illness, which may be reasonable in a child with fever and cough for a few days. But I always try to explain to my residents and students, if a child continues to have fever for more than 5 days, it's probably not just a virus. We need to look further. When we saw the child 2 weeks later, she was alert, she was tachypnic and wheezing, and she had some focal neurologic signs, including eye deviation and a hemiparesis on the left side. We admitted her to the hospital, got a chest x-ray, a lumbar puncture, and an MRI. This is her chest x-ray, which was read as bilateral and severe miliary tuberculosis. The arrow is just pointing to an area of consolidation in the left lower lobe. Her MRI and CSF were consistent with TB meningitis. She had one of the most dramatic MRIs that I've seen, with tuberculomas all over her brain, really kind of a miliary picture in the brain. Normally, I'm used to seeing 1 or 2 tuberculomas in my TB patients, but really she had many. You can see her spinal fluid also with an elevated white count of 27 with 80% lymphocytes and an elevated protein above 100. This is really just classic for TB meningitis in this patient. She showed this area here was a stroke, and then I'll show you a few more images that show the basilar inflammation that she had. So here you can see she has inflammation around the brainstem and the basal ganglion, and then more tuberculomas consistent with the basilar inflammation. It's classic for TB meningitis. We treated her with RIPE therapy for 12 months and prednisone for the first 2 months. This kid did amazing. I really didn't know how she was going to do, but by the end of the 12 months, she was an 18-month-old running around our clinic and talking. She had a little bit of weakness in her left hand, which actually she was getting physical therapy for and really did amazing. Here's her MRI 2 months into treatment, and you can see all those tuberculomas are gone, and we just see that little area of stroke here that she had. This is an interesting table comparing tuberculosis meningitis findings with bacterial meningitis and showing some of, you can see the odd ratios here. And the things that are most predictive are a high lymphocyte predominance. A white count under 1,000 is what they found in their study. My personal experience is more like under 500. And then duration of symptoms longer with TB meningitis than it is with bacterial. Bacterial meningitis patients usually come in within a few days, whereas TB meningitis is usually 5 days or longer, sometimes even weeks. And of course, the high protein is important as well, usually over 100. I've seen in some reports, 75% of patients with TB meningitis will have a protein over 100. So the way important for TB meningitis and patients with this, we want to rule this out in young children and infants with TB disease. Make sure there's no miliary or TB meningitis by getting a lumbar puncture. Ripe therapy for 9 to 12 months. And we usually recommend steroids for the first 6 to 8 weeks, followed by a taper. This is to help decrease the inflammation that goes on in the brain once we start treatment and the severe vasculitis these patients have. Initially, the symptoms worsen with treatment, causing an inflammation that's more intense. That's why the steroids are so important. And a lot of these patients will continue to have fever for the first month. I usually keep them in the hospital until they're neurologically stable, which usually is a couple of weeks, sometimes longer. Some of the complications we may see include seizures, syndrome of inappropriate antidiuretic hormone or SIADH. Hydrocephalus may be present at the time of initial diagnosis or come up later. Sometimes we'll have tuberculomas, strokes, and intellectual disabilities. And the mortality is high if these patients are not diagnosed and started on treatment as soon as possible. Luckily, we don't see this very often, but we usually have 1 to 2 a year in my practice. Okay, disclaimer here. I'm going to spend a few slides talking about pregnant women. I am a pediatrician, so I don't treat pregnant women, but I do take care of their children. And this is an older illustration that I really like because it shows the different ways a newborn could get tuberculosis. By far and away, the most common is going to be after delivery through airborne inoculation, either from the mother or some other contagious person that's been around the child. Rarely we'll see congenital tuberculosis that may be spread from the mother if she has hematogenous spread of TB during her pregnancy, so primary disease or miliary disease or meningitis, or if she has TB active of the genitourinary tract. I've only seen about 3 congenital cases in my practice over 30 years. It's not very common, luckily. And then Lisa Armitage, who does treat adults, let me borrow a few of her slides about pregnant women and tuberculosis disease. So women that are suspected to having TB during their pregnancy should be started on treatment right away. People are afraid and worried and nervous about giving women any kind of medications when they're pregnant, but all of the first-line drugs are considered safe in pregnancy. And of course, having bad tuberculosis during your pregnancy can be worse than any of the potential side effects. There has been some controversy in the past about PZA, and if it's not included in the regimen, 9 months of therapy, including rifampin, INH, and ethambutol, is recommended. What about PZA in pregnancy? Both the WHO and International Union Against Tuberculosis and Lung Disease recommend including PZA in the treatment with pregnant women. In the past, the CDC did not, due to a lower amount of data on safety. But in the more current recommendations from 2016, CDC did say that PZA was probably the benefits outweigh the risk, and it certainly should be included in the regimen in severe disease or in patients with HIV. What about after delivery? So we get this question a lot. Should the mother and the baby be separated? And the only time I would say yes is if the mother has multi-drug resistant disease, because I'm not sure what I would treat the baby with. But if the mother has regular tuberculosis that is not MDR, I would start the baby on INH or rifampin window prophylaxis, and then try to minimize exposure as best as you can. I usually recommend the mother and the baby sleep in separate rooms just to decrease the amount of time that they're breathing the same air, and the mom to wear a mask when she's around the baby. A lot of people ask about breastfeeding, and this is also important and should be allowed during treatment for tuberculosis. The medications do cross the placenta and the breast milk in low but safe levels. And certainly we know there are so many benefits to breastfeeding that it's safe for the baby. So take-home points for pregnant ladies with tuberculosis. Treating the mother helps the mom and also protects her baby, family, and prevents the spread of TB to others in the community. And of course, Dr. Devine talked in detail last month about how it is safe to do x-rays in women during pregnancy. You just want to use a shield. And pregnant women can be safely treated for TB infection and disease. And PZA, although controversial, in most cases, the benefits outweigh the risk of harm during pregnancy. Now on to treatment in children. So we have a number of options now that are new and better. We have the old standard of RIPE therapy for 6 to 9 months, and some of the newer options that I'm going to spend a few minutes talking about. The SHINE study, which was published this year, has already been endorsed by the WHO and is expected, hopefully, to be endorsed by the CDC sometime soon. This is a 4-month regimen of RIPE therapy for uncomplicated TB disease. And I'm going to spend a few more slides going over this. There's also a 4-drug regimen with rifapentine, moxifloxacin, isoniazid, and PZA that's been studied, published, and accepted in adults and children 12 years of age and over. This is for uncomplicated, mostly pulmonary disease, but it did include cavitary disease. And this regimen has been endorsed by both the CDC and the WHO. So this is really exciting to have these new shorter course treatments. The SHINE study was published in the New England Journal of Medicine this year. And this was a wonderful study, very well done. And they looked at children that were under 16 with smear-negative disease, asymptomatic, not severe, and drug-susceptible TB only. And they defined non-severe TB as no cavities, no miliary disease. If they had pulmonary disease, it was confined to a single lobe. And if they had a pleural effusion, it was not complex. No significant airway obstruction was another criteria. And of course, they did say any disease that was considered drug resistant, or if they had a drug resistant exposure, those patients were not part of the study. These children were randomized to either 4 or 6 months of first-line WHO fixed-dose regimens. Patients were given daily self-administered therapy. They did not use DOT, but they used checklist and pill counts and had an amazing 94% adherence. They also had an incredible retention of 95% at 72-week follow-up. The study was conducted in 3 countries in Africa, where most of the patients came from, and they also recruited patients from different sites in India. The age ranged from 2 months of age, being the youngest, to 15 years of age for the oldest, with a median of 3.5, so mostly younger children, which would be what we would expect. They included patients with HIV, and 11% of the patients were HIV positive. These patients were 14% were culture or expert confirmed, and meaning about 86% were clinically diagnosed. Most of them were pulmonary TB. 30% had a mix of both respiratory and lymph node, probably hilar lymph node disease, and there were a few patients, 3%, with peripheral lymph node disease. The outcome was amazing. They had non-inferiority with 98 to 97% favorable outcome in both study groups, and the power was good at 90%. This is a kind of an illustration showing the regimen that they used. For both the 4-month and the 6-month regimen, patients received INH, rifampin, and parazenamide. Ethambutol depended on the rate of drug resistance in the community and the rate of HIV infection. So both study groups were on the same regimen in the beginning, and in the continuation phase, they were both on INH and rifampin. Just a duration was 6-month completion for the 6-month group and just 4 months for the 4-month group. And then their unfavorable status at 72 weeks was exactly the same for the two groups. At 3%, the things that they looked at were death from any cause. And you can see here, we've got 7, just the number 7 out of the 4-month group, and 12 patients from the 6-month group had death. TB failure, treatment failure needing extension, they had 9 patients in the 4-month group and 5 patients in the 6-month group. And recurrence of TB, you can see here, also low numbers. They also look at adverse events of 3 or more, and the most common were pneumonia or liver, and they had exactly the same numbers at 8% for both groups out of a total of 1,200 patients. The drugs they used were the fixed dose combinations that the WHO approves based on the weight chart here. So the intensive phase, they used the rifampin INH pyrazinamide plus or minus ethambutol, and in the continuation phase, the rifampin INH combination based on the patient's weight here. And I have to tell you, we are jealous. We wish we had these regimens here in the United States. We're still crushing tablets. So the other regimen, 4-month regimen, is for adults and for children over 12. This was published in 2021 by the Tuberculosis Trials Consortium, and they looked at rifapentine, moxifloxacin, isoniazid, and pyrazinamide daily. The intensive phase was daily for 8 weeks with all 4 drugs, with the continuation phase for 9 weeks with moxi, rifapentine, and isoniazid. This regimen has been endorsed by both the WHO and the CDC. Eligibility were patients 12 and over, and they had to weigh at least 40 kilograms. They only treated patients with drug-susceptible pulmonary disease, although I did read there were a few with lymph node disease. Patients were not eligible if they were less than 12, pregnant, most extrapulmonary disease, or any risk factors such as prolonged QT syndrome, or patients that had been on partial treatment or had drug resistance exposure. What about monitoring children on treatment? We are so lucky because kids actually very rarely have any kind of toxicity. They really tolerate these medications well. We do monitor on regular clinic visits for compliance, adherence to therapy, and side effects. We provide our patients with education on what to expect and have them call us if they have any problems. Luckily, we don't have to get blood work unless the patient has signs or symptoms of toxicity or risk factors for toxicity. And in the United States, obesity is a real problem in children, at about 20% of kids being overweight or obese. And this is my #1 reason for checking liver function tests at the beginning of treatment, or if the child is on other hepatotoxic medications. Follow-up is important to check for symptoms and to reinforce adherence. And then when do we get x-rays? So there's not really any clear guidelines for children, but I always like to get one at the beginning, obviously, and the end of therapy, or if the child has some sort of clinical change in how they're doing. For TB meningitis, we usually get an MRI if you have that available at the beginning with contrast. I usually get a repeat about the time they're coming off their steroids, around 2 months. Sometimes we'll see new things pop up in that imaging, such as a tuberculoma or hydrocephalus. And then I also get another MRI at the end of therapy. It's always important when a child finishes treatment that they get documentation, because this will be important. As we know, the skin test and the IGRA presumably will be positive for life, and they need some documentation for when they go to school, college, or get a job. So in summary, pediatric TB disease, children have a higher risk of progression to disease, especially in children, infants, and kids under 2. Extrapulmonary and disseminated disease, including meningitis, are also more common in children, especially young children. The most common sites that we see disease in children are the lungs and the lymph nodes. And the subtle symptoms may be absent in children or maybe not present at all. And children less than 10 years of age have paucibacillary disease, so are usually not contagious unless they have AFB smear positive or cavitary disease. AFB smears and cultures are often negative in children, so we are left with a clinical diagnosis most commonly. And I should have put one more line in here about pregnant women, that these medications are safe and women during pregnancy with tuberculosis should be treated for tuberculosis. These are my references, which will be available on the Heartland website. And now I'd like to open up for any questions that anyone has. Thank you so much.
Okay. Hi, can everybody hear me?
Yes.
Okay.
Yes, we can.
We had one we had one question. I wanted to just say thank you to Dr. Cruz, who's been answering the questions in the Q&A box for folks who had questions there. And I wanted to bring up one of the questions that she answered that I thought was important. I loved the way she answered the question, but the question was, in fine needle aspiration of tuberculous lymph nodes, is FNA not risky for development of a draining sinus?
So
go ahead.
That's a really great question. So what I've read and what my experience has been is these lymph nodes are at risk for chronic drainage and chronic problems with this, especially if they have an incision and drainage. That's really going to cause more of a problem than an FNA. So a fine needle aspirate usually doesn't cause this problem, but it can. These nodes can also rupture on their own and have chronic drainage. So either way, but we want to avoid doing an I&D on it. So you don't want them to come in and incise it and drain it. If they're going to come in and incise it, they need to take it out. Or you can also put in a needle and aspirate the pus if it's an abscess. But a fine needle aspirate usually does not cause a chronic draining tract. And what did Dr. Cruz have to say? Because I can't see the chat.
Exactly that. That is exactly what she said. She recommended against I&D, and the fact that if you get enough pressure going behind the node in the first place, it can rupture, and that will almost consistently cause a fistula. And they're usually ugly and people are not happy. So definitely, definitely would recommend an FNA, or at least draining a tense lymph node with if you've got palpable fluid and you can decompress it, that would be the best thing. And then here was the other question that Dr. Cruz also answered. How would it work for infant immunizations if they're being treated for TB? And should they be postponed, or would it be okay to keep them on the regular schedule? And I would concur with Dr. Cruz. I would definitely keep kids on their routine schedule. And she did bring up, though, if you have a child on high dose steroids, you might want to wait until they have tapered the steroids before you proceed with the immunizations, just to make sure that they're going to have a full response to the vaccines. And she wanted your input.
That's a really, really great question. Actually, I'm a general pediatrician most of the time, and we take every visit when they come to see me for TB as an opportunity to try to keep them up to date on their vaccines. So we're handing out COVID and we're handing out flu. I want all of my kids vaccinated. So yes, absolutely. Unless they're on steroids, we go on and proceed with vaccinations on the record, on the schedule that they should be on. we do a lot of catch up because some of these kids are fleeing other countries and don't have their immunization records, and we have to catch them up.
Okay, and there's a question, how to manage both the fetus and the mother during the period of TB treatment. There's a lot of questions about treatment for TB disease in a mom.
So I've not taken care of any TB disease in moms. I might boot that to Dr. Armitage, but monitoring the mother and the baby like you would during pregnancy, I would think would be the main things you need to focus on. I know pregnant women may have a slightly higher risk of hepatotoxicity, so you may want to watch that a little bit more closely. But certainly if you don't treat the mom and she has severe TB disease, it's only going to make things worse. So we definitely want to treat her.
So yeah, absolutely. If you have a suspicion that a pregnant woman has TB disease, you absolutely want to start treatment. That is kind of the number one precept that you want. During the first trimester, if there's a concern for nausea, you want to treat the nausea. I used to have just hyperemesis of pregnancy. Would see that when I was in training in the emergency rooms, just the pregnant ladies come in and they get a little behind on the fluids, and we would give them 1.5 liters of fluids until they had till they got to the point where they had to pee, and then that was usually enough fluids to kind of tank them back up, and then we would give them Phenergan. So really just controlling any nausea that they would have. But I want to reiterate that what Dr. Smith had in her slides. The first line drugs are safe in pregnancy, and many of the second line drugs are safe in pregnancy as well. Dr. Barbara Seaworth is the medical director here at Heartland and has treated many pregnant women to successful pregnancy outcomes. I think one of the things you want to do is just let them reassure the mom that the medications are going to be safe. They're not going to have a negative impact on her child, and you want to treat and protect both of them. PZA is not as big of a controversy in countries outside of the US, and I believe Australia is the other country that has a question about PZA, but it is used worldwide. And for myself, when we manage our pregnant ladies here, I have to find a reason not to give PZA. For pretty much, we give all of our pregnant ladies get PZA, and a lot of times we're waiting for susceptibilities. And so that is the safest thing. And we have had many fat, happy babies that we've seen delivered to our pregnant ladies. So I would say that for all of we had several questions about how to manage patients with and how to manage the pregnant ladies. And I would just say, give the standard meds and treat any side effects that they may have. Let me see. Here's one question. If the patient has tuberculosis, is it convenient to be vaccinated against COVID-19?
I think it's important. I have really been emphasizing to my patients, I don't want them to get the flu. I don't want them to get COVID while they have TB. This would not be a good combination. We don't want them coming in with pneumonia or, respiratory problems from these viruses. So we really do emphasize both COVID and flu vaccines during treatment for tuberculosis. In fact, I'm lucky at our Harris Health clinics, they're allowing us to vaccinate the parents too.
There's one question about the urine LAM test. I will just say that is not a test that is I will just say that particular test is useful mostly in patients with HIV with low CD4 counts. So really, we don't see that as much of a use in either children or the pregnant ladies unless they have very advanced HIV. So I will just leave that over. I will leave that, for the answer for that one. How to diagnose and document extrapulmonary TB?
It's funny, Lisa, when I first started seeing children with TB, I thought, well, goodness, that they could have TB anywhere in their body. Do I need to just do a CAT scan of the whole body? I just was worried. But Jeff Stark, who was my mentor back when I got started, he kind of said, if you can't see it on an x-ray or you can't feel it with your hands, then you don't have to look everywhere. Now, if the patient has symptoms like abdominal pain, and my kid with the abdominal lymph nodes, you can go looking there. I've had a few kids with abdominal nodes, even retroperitoneal nodes. I had a kid in my clinic yesterday who was complaining of chronic ankle and foot pain. And it was her first visit, and we thought she had LTBI. And I told the resident, I said, you know, we really need to make sure that she doesn't have osteomyelitis of her ankle or foot. But being a teenager, you question her a little further, this pain lasts about 30 seconds and happens twice a month. So it is not osteomyelitis. But if a kid did have, you know, significant swelling of a joint or pain or a lump, I would get imaging and look for, because I've had a few kids with TB of the knee. I know Abby is going to present a kid we take care of with elbow TB. So if you do have complaints of pain that would make you think I need to look more carefully, then it's time to either do ultrasound or imaging or CT or, you know, other studies.
And there was one question, I kind of running through the ones that are a little bit more advanced. So MDR TB treatment in the first trimester in pregnancy can be done. I will just say that there are so many more moving parts with that, the amount of disease that is present, and the susceptibility pattern of the lady. The panel physicians have access to the portal to get to the COEs. We're here. So if you have that kind of question, I would absolutely recommend that you put your information for your patient in the portal, and we will get you taken care of. So the first most important thing is you're going to see that patient and you're going to let them know that you're going to be managing them, let them know that we can get them safely to delivery with a healthy baby with the current medications for MDR. So that would be the one thing that you would need to do. Let me see. A lot of questions about the COVID, and I just want to reiterate that I completely agree with Dr. Smith that it's so important. We've seen co-infections with COVID and tuberculosis, and it just wreaks havoc on the lungs. So having patients vaccinated, all of the vaccines, and remembering the flu shot, having vaccines for those do, you know, wonders for keeping babies and keeping mamas safe. Frequency of monitoring for adverse effects in children. So
I usually see kids back about every 4 to 6 weeks, and I give them my my office number so they can call me if they have problems before that. So we'll see them anytime they have a problem, but, you know, about once a month or every 6 weeks, just to see and we run through a list of, you know, toxicity symptoms that we ask them, a good review of systems. And normally these kids are fine. But if they're having any kind of signs of hepatotoxicity, then I'm you know, happy to check LFTs on them. We don't see a lot of liver toxicity in kids, but every now and then we do.
Okay. And then let me see, child-friendly formulation, child-friendly TB drugs. Don't get us started. We, you know, for our panel physician, you know, who are present on the call, you have a real pearl, and that's something that we don't have in the US. And I will reiterate, I will back Dr. Smith's statement that we are very jealous of having that. So an interesting question, TB diagnosis in children in the absence of IGRA tests.
In the absence of IGRA test, well, we didn't have IGRAs at all when I first started doing this, and we were using the PPD, and so the skin test, of course, can be used. It becomes an issue sometimes in patients that are BCG vaccinated, and certainly we would prefer an IGRA in that setting. But you can also diagnose them based on your other clinical criteria. So if dad has TB, a pulmonary TB, and the child has an x-ray that looks like TB, or the child, clinically looks like TB, you most likely have your clinical diagnosis there. Gastric aspirates may help you, or other samples. But if it looks like a duck and walks like a duck and quacks like a duck, it's probably a duck. And I think that the doctors around the world that see more TB than we do probably recognize it pretty quickly.
Okay, and I'm going to ask one more question, and then we're going to launch into actually let me see. Let me ask this one question. So the question was, are blood tests for TB something that can be ordered to diagnose TB in children that can't get a sputum specimen, since gastric aspirates are also non-conclusive at times?
So blood tests looking for a culture.
Blood cultures.
Blood cultures. So I have seen that done. I had one patient who had severe miliary disease, and we grew the TB from the blood, from the urine, and from sputums, all of the above. So any sample you can get a culture from, great. If you have disseminated disease, then you might have a positive blood culture. I do not know. Maybe one of the other panel physicians knows. I don't know the sensitivity of the blood culture.
The data I've seen, so cultures maybe about 40%, positivity. The smears down as low as 5 to 10%. But blood culture is just rare. I've seen that about maybe 1%. And so I think that would not give you more information necessarily than the gastric. But if you have a severely sick child, I would really recommend you can send the blood cultures, but urine cultures. Barbara Seaworth taught me that. If you have a patient with disseminated disease, frequently everything circulates through the kidneys. So you can sometimes get a positive culture from that. So I want to stop now and let's switch over to Dr. Geltemeyer is going to be presenting. So we're going to ask Dr. Smith to stop sharing, and then we'll have Dr. Geltemeyer give us her presentation.
Good afternoon. My name is Dr. Abby Geltemeyer, and I feel very fortunate to be part of this great group of clinicians who are involved in tuberculosis. Just something that I'm very interested in and really enjoy caring for patients of all ages. Oftentimes it is a family disease, and I'm just surrounded by a great group of people. And so my role in today's presentation is just to share with you some cases that I have seen along with Dr. Smith in the outpatient setting. These are pediatric cases because it's coming from our pediatric clinics, but I do have one related to a pregnant patient. And these are selected from last year. These diagnoses highlight just kind of those other variations in TB disease. And I thought these would be unique for our panel physicians just because these are all outpatient settings. And so I know we kind of already gave you a little prelude to this interesting case that we had of a 16-year-old who had 2 months of right elbow pain and swelling. And the initial workup did start with this patient's primary care physician. He was afebrile when this was occurring and really was seeking care just because it was starting to interfere with him doing his schoolwork. He's right-hand dominant and was having trouble. This was all during part of the COVID lockdowns still and involving some of the virtual schooling. So he was having trouble using his mouse and his computer, and he likes to play recreational soccer. And in fact, he thinks he fell, and that's what first made his elbow start hurting. He's now getting some secondary changes as it seemed to increase in size. His parents and siblings are healthy. They had no known TB exposure. They had immigrated to the US 3 years ago. So an x-ray was done that was suggestive of an effusion at the elbow joint, as long as a periosteal reaction around the humerus. And they actually were reading that as suspicious for a mass. And then they recommended further imaging. The family was actually not able at the time to afford an MRI. So they went for ultrasound. That also was just showing that there appeared to be a mass-like lesion. And if this elbow looks distorted to you, it certainly was, because this swelling or mass-like lesion was actually 4.5 centimeters. And so eventually this was leading to the need for an MRI. And this is part of the images that you can see. Again, that same swelling amount that we were seeing on the outside. And then here is this huge mass-like lesion. So the patient was actually referred to an orthopedist who did perform arthrotomy, and they did a second debridement 5 days later, just because of the amount of purulence. They sent it for several studies that did include AFB. The smear was negative. The cultures were negative. They had 1+ white blood cells noted on the Gram stain. And they decided to consult with an infectious disease group to guide the antibiotic selection. And this patient was sent home on clindamycin and ciprofloxacin. And so he was going to follow up with the surgeons 3 weeks later. And part of the problem that the family was noting was that he kept having this persistent drainage, a lot of pain, and there didn't seem to be a lot of improvement. And this is actually what the wound looked like when it was undressed 3 weeks later. And you can see just this terrible amount of material coming out of the wound. They did some repeat imaging, which actually showed that the prior area of swelling and what was a mass-like lesion had increased in number, it had increased in size. Interestingly, when they were planning that they may have to go back in and do further surgical care, within 24 hours, his AFB cultures actually came back positive. And that's when everybody started realizing this was TB. And he had a chest x-ray done just as part of the evaluation at that time that showed a calcified nodule in his right apex. Kind of giving us this whole picture of this being a site of reactivation and progression to disease from prior infection. And so 1 month later, the areas were finally starting to heal because he had been on anti-tuberculous therapy. And so he was diagnosed with MTB, osteomyelitis, and septic arthritis involving his right humerus, radius, and ulna. He underwent a year of TB therapy and 2 months of physical therapy and was able to make a full recovery. And so I guess the things that I think are key to take away from his clinical course were that the arthralgias, myalgias, swelling, and certainly any deformity are important symptoms that when you're evaluating anybody for either TB exposure, TB infection, or TB disease can signal that there is a musculoskeletal site of TB. And your treatment duration will certainly change. So those are important to note. And then the other case, I have a 9-year-old who came in with her mother for fever that had been present for 5 months. And mother's description was that it comes and goes, tends to almost occur monthly. When you ask the mother what level of fever the child has, she said 90 degrees. And you're like, that's not exactly a fever. And mother says, well, I'm not sure if the digital number is just broken, or maybe the thermometer is not working because the child is so wet. She's always sweating so much when I'm trying to check her temperature, measure her temperature. And so mother had been taking her to several different clinics. Each month, at least 3 of those occasions, she had been diagnosed with group A strep pharyngitis. Because this was certainly still part of our COVID pandemic, she had had numerous COVID tests that were all negative. And mother said really the only other symptom the child was having was 1 month of hair loss. There were no known TB exposures. They had immigrated 15 months ago. Mother and our patient's 2 siblings were healthy. She was making all A's. In fact, the teachers described her as an exemplary student. And she eats double portions. When she finishes her meal, she asks mother for seconds, and mom knows she can actually eat more. The child can eat more than her mother. On her exam, so this was what was happening with her weight when we were able to actually track down some of the other measurements at those other clinic visits. And this is what was happening with her height. So this is actually the 5th percentile going up to the 99th percentile on a growth curve. So you can see here her weight's actually falling, and as well as her height. Even though she's 9, she appeared more the size and physical characteristics of a 6-year-old. She was emaciated with some temporal wasting and pale. On her pulmonary exam, there were diffuse crackles and decreased breath sounds over all the lung fields, and she actually had clubbing present. So we did some labs, not really knowing from the start, since there was an absence of cough, whether there was actually tuberculosis here, but we were suspicious by the pulmonary exam. So she was anemic. She had, interestingly, a thrombocytosis, hypoalbuminemia, an elevated C-reactive protein, and her quantiferon was in the low positive range. And then this is what her X-ray looked like. So you can see marked disease, almost even like she has this compensatory hyperinflation going on due to the level of disease that she has. And the microbiology, this is actually one of the few cases that Dr. Smith and I have seen of a child in her age group who was AFB smear positive. In the 16 years I've been doing this with Dr. Smith, this is the first case that I've seen of a non-cavitary TB being smear positive, and also at this age group. So her first smear was positive. She was NAT positive, subsequently started to drop on her smears, and she was already being started on TB therapy at this point, and quickly converted her smears. Her culture did grow, pan-susceptible MTB, and she was treated for 9 months, and she made a great recovery. That's her weight and her height, showing how she was able to, with treatment, recover and start to obtain her full potential in her growth. And the other case that I wanted to present is a 6-week-old that we were called about to see in clinic for a concern for TB exposure. His history is that he was born preterm at 30 and 6-day weeks. So he was a twin. If you asked mom a little bit about prenatal history, the conception was via IVF. That also included donor eggs. Mother reported that she'd been told by her physicians in her native country that she had low ovarian production, and they weren't really sure if this was because she's very active. She likes to swim, she's run marathons. She's had one prior child who is 7 years old, but she and our patient's father had difficulty conceiving future pregnancies until the use of the IVF. Mother had actually come to Houston to visit her parents and sister 9 days prior to going into preterm labor. And after the delivery, mother did have fever, and she was found to have pyelonephritis. Over the next 10 days, she also had a complication with some of her abdominal wound dehiscing. She had delivered the first twin vaginally, but then the second baby, twin B, had changed and was presenting breech. So they then had to go to a C-section for that delivery. So our patient had been in the NICU for 31 days, just developing mature feeding skills, and had actually been doing so well, went home a little bit earlier than you would usually anticipate a preterm baby being able to go home. We usually say they would go home close to when they're 37 weeks. He went home really closer between 35, 36 weeks, had already been seen by a pediatrician in the community and was growing well. However, twin A had been in the NICU and unfortunately developed respiratory failure at 2 weeks of age, grew Enterobacter from tracheoaspirate and was treated for that. And briefly improved, but then started to deteriorate. And over the next 4 weeks, declined and did expire 3 days after twin B had already been discharged home. The parents had consented to limited autopsy, which involved the chest and abdomen of twin A. And the pathologist noted what appeared to be miliary pattern pulmonary lesions, but these were not pathognomonic for MTB. And there were no abdominal lesions. The pathologist was actually questioning whether there was an immunodeficiency that was present. So this was passed on to the neonatology team, who then contacted the parents and the pediatrician, who got in touch with the health department, who then sent the kid over for us to evaluate. So what are some of the key next steps? So we started wanting to figure out, if this is TB, where is this coming from? Is it mother? She reported having had a positive PPD. That was 19 years ago, before her college enrollment. If you ask her about TB symptoms, she had some rhinorrhea and cough 8 days after delivery, a normal chest x-ray, and no symptoms now. Father has diabetes and medically managed heart failure, but no TB symptoms. The sibling and the maternal grandparents with whom they've been residing are all healthy. This is how our baby is growing at this time, which is wonderful. Has a normal physical exam. We did a chest x-ray. That was normal. I did labs. I did a CBC. I looked at the albumin, really was just looking for any other signs that this baby might be sick. Besides clinical, I was like, I'm going to look hematologically. Those were all normal. We placed a PPD, partly because this baby at 6 weeks and just now being 37 weeks, corrected gestational age, we could not draw the volume of blood that was needed for the IGRA, because there are some restrictions on how much blood you can draw based on the weight of a pediatric patient. So his PPD was 13 millimeters. So at this point, very concerning that he has TB infection and is started on rifampin. And then the other big question is, who is the source case? Was this acquired around delivery? Was this acquired in the NICU? Or was this a case of congenital TB that's been transmitted from the mother? So reassessed this baby 2 weeks later, who's growing well by exclusive breastfeeding and normal exam. Mother had contacted the OB who had delivered her, because her actual OB was outside of the country that she had been following with. Her IGRA was positive. Father, brother, and maternal grandparents were all IGRA negative. Interestingly, at this visit, mother did ask at the time if there were any problems, because she's been on sertraline. She's been feeling very depressed with having to make funeral preparations for her lost child, as well as being stuck in a country that she doesn't usually reside in. And then she was taking acetaminophen and butalbital that had been prescribed for this headache that she was having and some back pain. She was worried if she could still breastfeed the baby, or if that interfered with his rifampin, which I reassured her at that time it was not a problem for her to continue those. And 1 week later, the father of the infant notices a swelling on the right neck that was non-tender. There was no erythema. Baby's continuing to be afebrile, growing well. An ultrasound of the neck mass showed this. And this was actually visible when you turn the baby's neck. I'm sorry, I don't have an actual photo. But this mass was measuring almost 3 centimeters of cystic compartments with debris and septations, with some mild increased color flow. And they were most suspicious that this was a necrotic lymph node, which was our concern when the parent called us as well, is that this infant is now showing that there is actually TB disease present. And this is just, there were 2 other nearby lymph nodes also. So we now have a 9-week-old infant with MTB cervical adenitis. Interestingly, we now have to convert to looking at by his age group. Are there other sites that are going to make us change our management? So, because we knew we needed to switch from monotherapy over to RIPE. We did repeat a chest x-ray at that time because we wanted to make sure if there's anything looking like miliary, or we now have a non-contiguous site involving intrathoracic lymph nodes, that this is dissemination and would require change in our duration. We did some repeat labs to look for signs of him being sick, which were also concerning. And at this point, you also have to look for CNS TB. So this patient now converted from an outpatient to an inpatient with his CSF being a little bit concerning that there were some early changes. And we actually diagnosed him with meningitis based on his cell count, but primarily his protein. And when I say the cell count, it's more of the shift in the lymphocytes and monocytes there. He did have an MRI of the brain that was normal. Gastric aspirate smears and cultures were collected and were negative. And we made the following medication adjustments to be treating for CNS TB or TB meningitis. Meanwhile, as I mentioned, it was the father who called us about the swelling in the neck. And the reason was because within 72 hours of mother asking me the question about her medications, she started having some acute clinical changes. Her headache and back pain had continued to worsen. She had had it now for over 2 weeks. She was feeling some weakness and paresthesias in her lower extremities and progressed prior to her presentation at an outside emergency room to bladder incontinence and unable to ambulate and fever. She had actually been to 3 prior emergency rooms over those 4 days where they had done things like urinalysis, chest x-ray, CTs of the head that were all normal. Fortunately, when she got to her emergency room with the current symptoms, they were able to actually start looking for CNS site of infection, specifically TB at this point. And so this was her LP results. You can see a marked protein over 1,000. And her imaging of her MRI, her imaging of her brain and spine showed she had a right lacunar infarct, and the spine showed findings of meningitis. Interestingly, they were looking for other etiologies for her lacunar infarct, and on her CT neck of the angio, they did see at the left lung apex, she had nodular airspace disease. And so she had AFB sputum smears that were collected. Those were negative, but her culture did grow, pan-susceptible MTB. She was started on anti-tuberculous therapy, underwent intensive rehabilitation, and actually made wonderful improvements. And so that's all for my presentation. I'll try to keep it within the allotted time frame. Thank you.
You did a great job, Dr. Geltemeyer. And now that your PowerPoint is has concluded, can you go ahead and flip your camera back on so we can ask you some questions and see your lovely face while you answer them? Excellent.
Is it on?
Yep.
There we go.
Okay.
Okay, I don't think any new questions came in. This one was one that was left over, and I'd be interested in the other pediatrician. So, is a positive TST result reliable in a child under the age of 2 years who is born in a country that routinely immunizes with the BCG vaccine? Should an IGRA be collected if the TST is positive? Seems like a simple question.
This is Kim. I always like to check an IGRA in a patient that's BCG vaccinated, but we also want to consider the clinical setting. Any child that has a positive skin test or an IGRA, or even a borderline for either one, who has been around someone who's contagious or has symptoms of TB, we would take either test as positive. We keep going younger and younger with our IGRAs, but I certainly feel comfortable, and I've had some very young children where we did an IGRA instead of a skin test. But a positive skin test certainly could be due to the BCG vaccine, so the IGRA may help you kind of sort that out. I don't know what, I'd be interested to hear what Abby thinks and what Lisa, what you think, and Andrea as well.
Yeah, and I think, because of the talk that we're on now, it's important to note that DGMQ wants children down to 2 years old to be to have an IGRA, and it's just for that reason. I mean, if you think about it, these are the ages of individuals that most recently saw the vaccine. So a false positive with a skin test is more likely. So the tests are comfortable down to 2. And we had this conversation when we spoke when Dr. Cruz was speaking with us about diagnosis. And we were saying that most of us are very comfortable going down to 1 year of age with the IGRA. So if you have the option, in the country that you are, to do testing down younger in children, but that is not necessarily required for a child to immigrate to the US. So if what you have is a TST and for your documentation purposes is a TST, but if you're, that kind of leads into the next question, how do you manage IGRA positive kids with a normal chest x-ray? So before you decide that you're going to treat a child, you may want to have better information. So I would agree, at least down to a year of age. And just like Dr. Smith said, that the numbers the ages keep going lower as we get more and more data and more information about how to use the test in younger children. But I can't not emphasize enough, you have to do a history around that child, because if that child is in the household with someone who has active tuberculosis, any positive test, you should be considered. So Abby or Andrea, did you have anything else that you?
Well, I guess my thoughts were, with us being a TB referral clinic before the IGRAs were really routinely used, especially without an approval in pediatric patients, we have so many community physicians, nurse practitioners, and clinics who see our patients that are part of the county hospital system. And so we have a huge basically patient base, and most of those patients are immigrant, especially when you're talking about that they're serviced by the county hospital, so they don't have private insurance. And our community pediatricians were going by the TB screening questionnaire, which is if you were born in an endemic region, you had a risk factor and they had to test because that's required by Texas guidelines. And we would get in, maybe like in a month, 20 referrals. And so they were testing all these kids who were BCG vaccinated already. And so their skin tests were being negative. And so I would say that don't let that, my teaching is always don't let the BCG hold you back. Still do your test. You still need to know if that kid has TB infection or not. And don't expect that it's automatically going to be positive, because that's not what we've seen in the community. It'd probably be a great study to do and actually publish that information, because it's, I guess, anecdotal. I'm just saying what I've seen, but yeah, there's so few kids that would actually test positive that would get referred to us out of so many that were tested.
So we were also, and early on, we were also, whenever we got those kids, if they were BCG vaccinated and had a positive skin test, we would go on to confirm that with the IGRA. And it did turn out that about 20 to 30% of our referrals were negative, which we, on the IGRA, which we decided was a false positive skin test. We wouldn't even do the IGRA if the child had been exposed to TB or, there was a HIV infection or something like that. But now the IGRAs are widely available, and most of the people in the community know to start with the IGRA in a child that is BCG vaccinated, and that's improved our, cut down on some of those referrals that we were getting before.
And this is Andrea. Sorry, I have the camera off because I'm post-call and always look scary post-call. But I think that the national guidelines are really, not intended with this audience in mind. They're intended for, our colleagues who are on the front line providing, general pediatric care, and they might be seeing 40 to 50 kids a day and might not have the time to be able to dive into TB risk factors the same way that we do. And so, I think about a busy TB clinic pales in comparison to what my colleagues who do community pediatrics care for in terms of patient volume. So I think, the guidelines are understandably conservative with the audience in mind of the people who should be doing the most screening, which in a perfect world should not be us, right? Should be our primary care colleagues.
It was just a technical question. How long after a TST can an IGRA be done? I had heard at one time there was a time limit between the when the TST is placed and when the blood should be drawn for the IGRA. I have some kind of strong feelings on it. I'll let others go first. But I will, just to jump in there, I would say, so the question was, can you get some boosting? So always, if you place a skin test, and you do a second skin test, you can boost a response. And technically you could do that with an IGRA, but I will say that you cannot boost a response that's not already there. The IGRAs are specific for MTB antigens, so you're not just non-specifically boosting a response. So I would say that, any time after, I would not put a limit on it. If your IGRA is positive, it's not going to be because the person had a skin test. The antigens are too small to actually elicit a positive IGRA. If they have a positive IGRA, it's because they're positive. So
yeah,
now
I don't wait. I just do it
just
when
do it. Right.
Because I think if you wait, then those are the kids you lose.
Yes. And I think the waiting came from the live vaccines. So if you can get a false negative result if you give a live vaccine and then you do a TST, so that the people hear that waiting and that, fear of boosting if you do consecutive skin tests. But this is a little bit different. So I'm with Andrea. You're going to lose patients if you're waiting around for something. I would do the testing pretty much immediately. And here's a question for you. So when you had, let's see if I'm make sure I read it right, with one baby who was diagnosed with TB and with no other obvious source, would you ever have considered treating the mom as a clinical case before she was diagnosed?
Yeah, that was, for me, I felt terrible that I had seen the baby and the mom had asked me those questions about the medicine she was taking for her headache. And I was just amazed at how quickly the TB progressed in her. Mm-hmm. And I was like, wow, I could have done more to advocate for her, especially being an internist. And that's why I wanted to present the case, was just, it taught me so much about just how you have to really suspect TB, I guess, for me and in her. And there was a lot of focus at that time where I thought, I don't know if the TB came from the NICU or if this is the mom, but I'm starting to get suspicious that maybe mom has TB. Mm-hmm. And yeah, I wish I could have gotten her treatment sooner. I wish that I could have been seeing her as a physician and been her doctor and prevented her from getting a stroke. That was horrible to me for this family. So yeah, to be able to share with others how that whole prematurity that she had, problems with conception beforehand, and just recognizing how does congenital tuberculosis present, which has been such an eye-opener to me, that 2 weeks of age is where those neonates start to get sick. And I think I'm hearing that in all these talks, and including the one the last session on part 4 from Dr. Devine, is that having suspected sooner that mom was the source case and that mom had disease, could there have been a better outcome for her? Sure, no question in my mind. That wish I could go back and change something. Sure.
So for the questions, TB investigation in pregnant patients, I really, honestly, other than shielding the abdomen, doing a lead shield on a pregnant abdomen, most of the other ones are all the same. You know, the question of the IGRA, the TST, and chest x-rays in pregnancy, all the same, just important to shield the abdomen and reassure the mom. And do pregnant patients take drugs on an empty stomach? I don't know that I would try that. I think that getting the pregnant ladies to take any medicine on an empty stomach is probably not wise. I would, if they can take the meds on an empty stomach, it doesn't upset their stomach like any of your other patients, it's fine. If not, I would definitely recommend that you ask mom to have a small snack to see if that would help. So, and back to that, I think I asked this question before, how do you manage IGRA positive kids with a normal chest x-ray?
I usually do a careful physical exam and review of systems. And if we don't find any lymphadenopathy and they don't have any pain anywhere, I would diagnose them with latent TB infection and treat them if they have a positive IGRA and a normal chest x-ray. That was the question, right?
Right.
Yeah.
I completely agree. Don't forget to do the physical exam. Just you're doing a careful physical exam, looking for adenopathy, and you're querying the parents about, you know, weight loss or growth or concerns that they have, night sweats, any symptoms that would suggest tuberculosis before you start treatment for LTBI. But I think a lot of it is, you know, for the physicians overseas, you have to consider how long it's going to be before the child immigrates to the US. If you have 3 solid months, you can do the INH rifapentine regimen, or you can do daily INH and rifampin if you have at least 3 solid months to treat before they leave. I think we have a lot of kids that arrive here and they don't want to start treatment overseas, and they have it interrupted when they come here. And our next webinar is going to be the US experience of the patient. So for our panel physicians, when you're sending the patients over, Jeff Stark's going to talk about what happens when they get here to get evaluated. But if once they're here, what we would do is basically treat them for TB infection, for LTBI, with those findings. And had one, oh goodness. For a patient with BCG, do you have a cutoff for the TST measurement to where you would not do an IGRA anymore? For example, if the TST is 15, would you not do an IGRA anymore?
I would still do an IGRA. I've seen we used to talk about, you know, the BCG, the bigger the measurement, the more likely it was true. But my experience with since we've started using IGRAs is really the size of it. I don't think it really makes a big difference. Because I've seen kids with, you know, 0 on their skin test and a positive IGRA, and I've seen kids with a big, you know, 15 or bigger TST that comes back with a negative IGRA. So I just think it's in a kid with BCG vaccine, I think an IGRA is the way to go.
Mm-hmm.
Also, a lot of times you don't have that skin test to look at yourself.
Yes.
You're going off of hearsay.
Good
and
point.
It's like every skin test is like 10 or 15 millimeters. And, you know, which the moment you have a TST result that is divisible by 5, I start being wildly skeptical that anybody actually measured it, as opposed to like looking at it with, you know, from across the room with one eye slightly squinty. So yeah,
I will confess to the panel physicians, when they wrote the technical instructions, they asked me to sit on as a pediatrician, and I told them that everybody has a 10 millimeter TST. It's never 9 or 12 or 11. It's 10 millimeters, because that's the number. And so that got to be the joke among our group, but that's, you know, frequently, just like you said, you can't see it. And I'm sorry, Andrea, that I interrupted you, but I just wanted to kind of back up your point on that.
Yeah,
And
no,
that's-
I'm always amazed by it. I'm so tickled when I get the 14 millimeter skin test. I was like, oh my gosh, this
Somebody
makes me think
measured
somebody actually used a
So
ruler. I
measured.
still don't necessarily believe it, but I actually believe that they measured it.
It's also interesting how often I ask a kid, did they touch your arm when they measured your PPD? And I'd say at least a third of the time they just looked at it. You know, that nobody touched it and nobody put anything on it to measure it. So it's such an unreliable test. And here in the United States, many healthcare providers really don't have experience reading positive skin test.
And Jen, in reference to your question about TB testing and the challenges inherent to TB testing, number one, it is ironic that your school district actually doesn't adhere to CDC or AAP recommendations about testing of children, because the kids should be screened for risk factors, and if they're risk factor negative, you should just stop. But one thing to think about is, even if you can't get quantiferons done in your setting, and I only say quantiferons just because it's commercial in the commercial lab space, it's an easier test to obtain typically. You can send them to LabCorp or Quest or one of those labs to get it obtained. But probably the solution is to, have a heart-to-heart with your school district, the people who are making a school district policy, to see if you can't get your school district in line with national recommendations.
Okay, and I think most of the remaining questions, first line treatment for children and dose management according to age and weight. And I think Dr. Smith kind of covered that. If I'm going to invite, if there are any additional questions that you felt like weren't answered, then please throw them in the chat box and we'll get them addressed now. But I think, I would thank Dr. Smith for very, carefully going through that. Monitoring for side effects in pregnancy, I would say hepatotoxicity is a little bit more prevalent. So you want to make sure that you're doing the monthly screening for liver toxicity, and that especially the peripartum area, the last trimester, and then the 3 months after, that you're watching over and not letting the pregnant ladies, don't miss the blood draws, and make sure that you're watching the liver. Other than that, just controlling nausea if they have morning sickness is the biggest thing, and making sure that nausea is not due to liver toxicity. I would add that on as well. And again, for the rest of it, there was one interesting question. What about the use of molecular diagnosing replacing chest x-ray? I think I would say that I would use it to enhance, chest x-ray, but I really, and Dr. Smith showed some very nice films of lymphadenopathy, close to the hilum, and especially around the mainstem bronchuses. You would want to know, ahead of time, before you started treating a child, if they would have some worsening lymphadenopathy. You would never know. They'd just be, you'd start having some respiratory problems that you weren't aware of. So I want to pass that one on to others.
Well, in children, at least in the United States, we're not allowed to do molecular diagnostic tests unless they're smear positive, which is almost never the case. So we're not going to have that luxury. I agree, it would be more of an enhancement if we could have the molecular test. But I think we're stuck with, we really do need a chest x-ray. On the other hand, if you have an adult who's really coughing up a lot of sputum and you have a positive sputum AFB smear, and in that, or our expert, you've got your diagnosis. I guess in resource areas where you don't have the resources to do the chest x-ray, you may have to go on clinical grounds, but I would still think an x-ray would help you to know kind of how severe the disease is and follow it over time. I have to say, I'm going to add, I didn't really go in a lot on the dosing of children for TB disease because of the fixed dose regimens they have, that the WHO has. But there is a lot of really interesting data, pharmacokinetic data, showing that children under 2 do need a higher dose of rifampin than children over 2. And we have those specifically in the CDC recommendations for dosing in children.
Right. I'll ask Dr. Smith to share her table with the fixed dose dosing, and then also One of the things that very prized in our center, Dr. Smith has worked out for the weight bands, how much of each of the first 4 line drugs you would treat with. So we will have that table that she created available in the physician and the panel physician portal, along with the slides and the recordings from the talks for today. So we'll have all of that information, and then we'll get with Dr. Smith and make sure that we have the latest and put those in there as well. So if you're looking for what to treat, I think one of the most important things is not to forget that when you're dealing with children, they grow. Whereas your adults may pick up some weight and they won't change significantly within the weight bands that you're used to treating for the TB medications, children may grow into the next range, and you want to make sure that you increase the dose to follow them so that they're getting adequately dosed. I think people forget that sometimes, that little people do grow. And I think that is I think we've actually exhausted all of our questions. We're getting pretty close to time. So I would invite our 2 speakers if there are any final thoughts that you wanted to leave for the audience today.
Well, I really appreciated being a part of this. I think it's been a wonderful symposium, and I look forward to hearing Dr. Stark's presentation next month. And thank you for inviting us. And I think Abby did such a great job with her cases. Thanks.
Excellent. Completely agree.
And we also appreciate your backup on the pregnancy part, and Andrea taking care of some of those chat questions while we were presenting.
Right.
Thank you.
If you have, and I will say to the panel physicians, if you have any additional questions, I know that some of you are going to watch this, and we knew that when we presented that somebody was going to get what I call the midnight to 5 a.m. slot. So you're probably tucked safely in your beds. But if you watch this going forward and you have questions for the presenters, let us know, and we'll be happy to push the questions forward or make sure that you get your questions answered. And I would say, if I had one parting thing, the pregnant ladies, we are at a time where we're being so effective in treating the pregnant women with TB. You're treating not just one life, protecting not just one life, but you're protecting 2, or if they have multiple babies, 2 or 3 lives. And so being fearless in the diagnosis and treatment of TB in the pregnant ladies gives us nice, healthy babies. And regardless of whether the mom has extensive disease, we've treated moms with miliary TB, and we've treated moms with MDR TB, and we've had excellent outcomes. So just reassuring the mom that both she and her baby will be safe. Mostly her baby will be safe, and she will be here safely to care for that baby. Just reassuring them up front. And then if you have any questions going into the portal, we have 4 centers that are here to answer any questions that you have. And so if we're all done, I wanted to thank our presenters and our panelists and for sharing their knowledge here today, and just such good presentations. And again, they will be available for a review later on. And so if that's it, I'm going to hand it back over to Lauren, who is our host.
All right. I also want to say thank you very much to Dr. Smith and Dr. Geltemeyer for joining us today. Thank you, ladies, so much. It was wonderful getting to work with you, and you gave such great talks.